Hello, my name is Dr. Shyam, and today we are going to talk about pseudomembrane colitis, which is also called C. difficile colitis or antibiotic-associated colitis. So what happens is that these antibiotics, which I'm going to mention in a few seconds, they cause the disruption of gut flora. These broad-spectrum antibiotics, they disrupt the gut flora, leading to all the symptoms of difficile colitis. Actually, disruption of gut flora causes the inflammation of the colon, leading to all those symptoms, which are severe abdominal pain, diarrhea, that is most important. That could be either bloody or non-bloody diarrhea, but it's a severe diarrhea, severe abdo pain, abdo tenderness, and the fever. Now, the symptoms can begin as soon as within 1 to 2 days of starting these antibiotics. So, which antibiotics are most commonly associated with pseudomembrane colitis? These are penicillins, cephalosporins, fluoroquinolones, carbapenems, importantly clindamycin, and some other medications like PPIs. They can also be related with the pseudomembrane colitis. So how are you going to diagnose that one? So you're going to take some history, definitely, and importantly, you're going to send stool sample for C. difficile A and B toxin. A and B toxin. Okay? This is how you're going to diagnose the C. difficile. You're going to send a stool sample for stool testing for C. difficile toxin A and B. Then the other things you can do is that you can do CT or an X-ray. You know, one of the complications is toxic megacolon. So that's over there. Then you do a sigmoid or colonoscopy. You know, you see the yellow plaques over there. Normally, you don't do a sigmoidoscopy. It's C. difficile toxin that, and your history and examination, and will link with the antibiotics. That's more than enough. But in severe cases, you need to do a colonoscopy or a sigmoidoscopy to see that those yellow plaques over there. Now, importantly, you classify C. difficile infection. Either it's a mild or moderate or severe. So if the WBC counts, let me change the color. So if the WBC counts are normal, they are not raised. WBCs are not raised, they are normal, and you have 3 episodes of diarrhea per day. This is mild infection. If WBCs are greater than 15 and you have 3 to 5 episodes of diarrhea, that is moderate infection. Severe means WBC is greater than 15 and you have the other things as well. What is that is increase in creatinine 50% from the baseline. Increase in the creatinine, or the temperature is greater than 38.5, or there is evidence of severe colitis on radiological or abdominal examination. What I said earlier is toxic megacolon. If you find that one on a CT or an X-ray or on an abdo exam, and you have like greater than 15,000 TLC count, that is white blood cells, and increase in a creatinine greater than 50% from the baseline, you've got higher temperature. This means that it is severe colitis. The complications could be, before the treatment, let's discuss the complications. So it's the diarrhea, it could be dehydration. As I said, in the severe, there is an increase in 50% of the creat from baseline. So this means AKI, kidney failure. Toxic megacolon. Toxic megacolon is treated with the surgery. If not treated, that can lead to bowel perforation. And unfortunately, if not managed properly, one can die of the bowel perforation. Now, most importantly, let's talk about the treatment. What is the treatment? So definitely it's the diarrhea. You're going to give the IV fluid. Okay, that's a supportive treatment. Okay, what is the definitive treatment? So if we talk about the first line treatment. Then we're going to discuss about what to do in a recurrent cases and what to do in life-threatening condition, colitis. What we need to do for that. Okay, let me change the color. Yeah, that's fine. Okay, so first line is oral vancomycin. You give it for 10 to 14 days, 125 mg QID, means 4 times a day. That is the first line treatment, oral vancomycin. Now, if it's a recurrent within 12 weeks, like you have given the vancomycin, okay, for 2 weeks, 10 to 14 days, but it's recurrent within 12 weeks, so you need to go for, now you can't repeat the vanco, you have already given that one. So the option over here is oral fidaxomicin. You give it 200 mg BD for 10 days. So first line is oral vanc. If it's working, that's done. If there's another recurrent infection, which is within the 12 hours of the first infection, you give for oral fidaxomicin. If it's above the 12 week, it's up, somebody has got C. difficile and you treated that one, and it develops again the C. difficile after the 12 weeks, so you can go again with the oral vancomycin. But if it is within 12 weeks of the initial infection, it's again a recurrent, you need to go for oral fidaxomicin. Okay, so in the life-threatening condition, you go for oral vanc plus IV metronidazole. You need to combine both of them. In the life-threatening, and in severe cases, that's I already said, increase in creatinine, higher temperatures, it's toxic megacolon. You need to go for oral vanc, but here you add IV metronidazole. Now, importantly, let's discuss over here that if somebody is not able to tolerate the oral, if it's not taking the oral, some of our patients, they can't take oral, okay? Either they have a swallowing problem, or what we need to do in those cases. So normally, if it's a mild or moderate, in those cases, if they can't take oral, with either they have a swallowing issues, you need to go for IV metronidazole or IV fidaxomicin. So in case where you can't give the oral, the patients who have swallowing issues, you can go for IV metronidazole and IV fidaxomicin. Lastly, this C. difficile toxin A and B, it stays positive for 6 weeks after the infection is successfully treated. So here you can see a colonoscopic view of large intestine. So this is what we find in pseudomembrane colitis, these yellow raised plaques, multiple raised yellow plaques. Sometimes they are a bit hemorrhagic as well. So this is a colonoscopic view of the large intestine having plaques showing pseudomembrane colitis.